Welcome everyone to today's program. I am Mary Rectoris with Becker's ASC Review. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during this time. You will also receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at this time. This email will not include the presentation. It is now my pleasure to introduce today's speaker. Barbara Connell is the Vice President of Clinical Services at Medline Industries in Mundelein, Illinois. She earned her master's degree in healthcare administration from the University of St. Francis in Joliet, Illinois, and a Bachelor of Science degree in medical technology from Creighton University. She has 20 years of experience as a medical technologist working at various levels of the lab, specifically in the areas of microbiology, infectious diseases, and hematology. She also has 15 years of experience in the IVD laboratory diagnostic business, where she focused her love of science on new product development and the execution of scientific studies. As Vice President of Clinical Services, Barb is responsible for the development and execution of Medline's infection prevention programs. It is now my pleasure to turn the floor over to Barb to begin today's presentation.
Thanks, Mary, for that kind introduction. So welcome, everyone. And today's topic, we're going to talk about getting to the point of safe injection practices. Next slide. And these are just my disclosures. Next slide. So the objectives for today's presentation, things that you should be able to walk away with, are the following. First, we're going to define safe injections and other basic infection control practices and be able to recognize and correct unsafe practices. You should be able to describe the potential consequences of unsafe injection practices, understand the basic mechanisms of infectious agent transmission via unsafe injection practices, highlight best practices when performing point-of-care testing to reduce the risk of transmitting bloodborne pathogens, and finally, you should be able to understand the need for monitoring injection safety and basic infection control practices in your facility. So that's an awful lot, so we should get going. Next slide, please. So what exactly is injection safety? Well, basically, it's measures taken to perform injections in a safe manner for patients and providers. Specifically, we want to prevent transmission of infectious diseases from patient to patient, patient to provider, or provider to patient. Next slide. This also means that we want to prevent harms. So in practicing injection safety, we want to make sure that we do no harm to the recipient, we don't expose the provider to any avoidable risk, and our practices don't result in waste that's dangerous for the community. So all in all, what this really means is that injection safety really needs to be part of our standard precautions. And that means that they should be used on all patients or residents in all settings at all times. Next slide. So this document, Guideline for Isolation Precautions Preventing Transmission of Infectious Agents in Healthcare Settings, 2007. This is really the guidelines that were put out by the CDC. And it talks, you say, oh, they're isolation precautions. Well, this document was originally developed in 1996. And next slide. And over the years, some things have happened in healthcare that really have really told the CDC that these guidelines needed to be updated and certain things needed to be included in these guidelines, injection safety being one of them. And some of the changes that happened, number one, the delivery of healthcare is certainly different these days. Not so long ago, healthcare really took place in that acute care hospital. And everything was there, and you didn't leave there until you were ready to come home. But today, healthcare is more patient-centered, and actually we try to provide as little as possible healthcare in that acute care setting. And patients go to all sorts of different settings to have their health care delivered. Home care, ambulatory care, ambulatory surgery centers, physicians' offices, long-term care. So as I said, in 1996, that was when the first guidelines for isolation precautions came out. But standard precautions, because there was so much evidence that showed that these worked, this was really a reaffirmation that this standard precautions really needed to be the foundation of this document to help the prevention, the transmission of infectious agents in all healthcare settings. So not just in the acute care hospital, but in all healthcare settings. And the other reason it was updated was because there was a strong evidence base that said that that could tie outbreaks of hepatitis B and C viruses in ambulatory settings, and it really indicated that there was a need to reiterate the fact that safe injection practice recommendations needed to be part of standard precautions. So there's a whole section in this document that that talks about safe injection practices. Next slide. So here's some headlines. We know that we are very much a media-oriented society these days. You have this first mention of an outbreak. This is from 2001 in Newsday out in Long Island, the syringe mess. 8,500 more at risk. Every patient the doctor treated for 5 years should be tested, health officials say. So that's a pretty eye-catching headline. And this isn't in an Inquirer type of newspaper. Unfortunately, somebody stole the little boy's Christmas lights, and Donald Trump was up to something back in 2001 there too, but we won't be talking any politics today. And then in the other document over there, again in 2001, there was a hepatitis outbreak in New York. New York had a bad year that year. The doctor did it. Anesthesiologist contaminated vials of medications with dirty needles. Next slide. There was this document that was published in 2015, and this came from the CDC. And this report actually outlined only the outbreaks of hepatitis B and C between 2008 and 2014. And I thought that this was really pretty important and kind of amazing. Between 2008 and 2014, there were actually 44 outbreaks, so that meant 2 or more cases of viral hepatitis that were related to healthcare incidents. And of these, 42 of the cases, or 95% of them, occurred in non-hospital settings. So that's really telling us that these outbreaks are very prevalent outside of that acute care hospital. Next slide. These were probably 3 of the largest outbreaks that have happened in the last 10 years. The first one was once again an outbreak of hepatitis C, and this was in outpatients at a hematology oncology clinic in Nebraska. And 99 patients who were there to get their chemotherapy left with hepatitis C. And it was all, they genotyped the virus, and it was all the same virus, so they knew that it came from one location. And in this particular case, what had happened was the nurse drew blood from an IV catheter. Then she reused the same syringe to flush the catheter with saline. Now, she did use a new syringe for each patient, but what she also did was she used solution from the same 500 cc IV bag to withdraw the flush solution. So that first syringe that she used contaminated the bag, and she contaminated 99 patients after that. In this particular case, the oncologist and the RN had their license revoked, and if you want to read more about that particular outbreak, it can be found in the Annals of Internal Medicine from 2005. Another big outbreak of hepatitis that occurred was at an Oklahoma hospital where a nurse anesthesiologist reused needles. And basically, what she did was she pre-filled a syringe with enough sedation medication to treat up to 24 patients. And so she used the same syringe and injected it through the hep lock and basically transmitted hepatitis C to 31 patients and hepatitis B to 69 patients with hepatitis C and 31 patients with hepatitis B, and it cost them $25 million to settle that case. Probably the largest outbreak of hepatitis C was in Nevada in 2008, and these were actually endoscopy clinics, but the outbreak did not come from the scopes. We saw those and we talked about those last year. In this particular case, there were 50,000 people were exposed. It ended up there were 8 acute cases of hepatitis C with another 106 potentially linked to the same outbreak. And what had happened in this particular case was they used the same syringe and they shared single-dose vials. I believe that the owners and some physicians went to prison for that outbreak. Now, you're probably saying, well, Barb, these are all old cases, and why is this still relevant? Next slide. Well, as I was doing my research for this particular talk, I came across this, and this was published in May of 2015 by U.S. News and World Report in their health section. Once again, unsafe injection put patients in peril. More than 150,000 people have been notified that they were potentially exposed to unsafe injection practices. Now, that wasn't in one outbreak, but they were saying, over time, all these people were exposed. So it's still in the news. And then this little gem came across my desk. Next slide. And this was an article that was actually published in AJEC in April of 2016. Very timely for this talk. And this was a study that was actually done. And what they did was they trained medical students to be observer of infection prevention practices, specifically hand hygiene and injection safety in different outpatient centers. So these medical students went to some ASCs and they went to some physician offices, and they just kind of hung out and they looked for potential injection safety observations and hand hygiene observations. And what they saw was they had 163 injection safety observations that were performed, and it revealed that medication vials, the rubber septums, were only disinfected with alcohol 78, almost 79% of the time before they were pierced with a needle. So that meant 22% of the time those rubber septums could have posed a risk of transmitting an infectious agent to a patient. Now, the hand hygiene results probably will not surprise anybody. Of the 330 observations they observed, 37% of they used no hand hygiene. And once again, that is discussion for another time. Next slide. But go ahead, next slide. But hand hygiene is really part of injection safety, because if you start out with hands that have not been washed, you do have the potential to contaminate your medication vials and the other equipment that you're using. So make sure you keep that in the back of your mind. All right, so what type of unsafe injection practices occurred to cause these outbreaks? Well, really, they were associated with a wide variety of procedures, so it wasn't any one particular kind. They happened with the administration of anesthetics for outpatient surgeries, diagnostics, and pain management procedures. There was administration of other IV medications, chemotherapy, cosmetic procedures, and also alternative medicine therapies. outbreaks happen with unsafe practices in regards to flushing IV lines or catheters and the administration of vaccines. Next slide. So what were some of the unsafe practices that happened to cause these outbreaks? And these were kind of the top four. There were others, but these are kind of the top four. And the number one thing, the number one unsafe practice that caused outbreaks is syringe reuse between patients during medication administration to multiple patients. So just carrying on that same syringe. Contamination of medication vials or intravenous IV bags. Failure to follow basic injection safety practices when preparing and administering medications to multiple patients. So we'll talk a little bit more about that. And of course, inappropriate use and maintenance of finger stick devices and glucometers. Next slide. So when I think about safe injection practices, I love this poster that came from the One Needle, One Syringe, Only One Time campaign. And I think that this would be a great training tool for you to use. Just use that Q-tip in your ear and ask if anybody else would like to use it when you are done. And I think that that is really a thing to think about. Replace that Q-tip with a syringe and a needle, and I think you kind of get the point. Anyway, next slide. So it was kind of interesting because, you know, we just talked about some of the unsafe things that were done that caused these outbreaks, but they actually asked some of these providers and clinicians to justify why they reused syringes. And some of these answers are kind of interesting and fascinating. Number one, there was a mistaken belief that they were actually following prevention infection practices to prevent the risk of transmission. They thought that because they were changing that needle, that syringe was safe, and we know that's not the case. There were also cases where they believed that because they were injecting, because they were injecting through intervening lengths of intravenous tubing, so they had this long tubing, they could use the same syringe because maybe somehow the virus or bacteria was diluted through the tubing. I'm not sure. I can't really explain that thought. They also thought that, well, there was a check valve there, so I could use the same syringe. Not true. Check valves do not have any device inside them that can prevent bacteria or viruses from being filtered out. And they also said, well, they maintained pressure on the plunger, so there certainly couldn't be any backflow of body fluids into the syringe, so that syringe was not contaminated. And we know that all of these things on this list just are not true. Next slide. So what can really happen when you don't follow safe injection practices? Well, we know you can transmit disease to patients. Notification of thousands of patients who've been exposed, so you get them all worked up, and then you have to recommend that they be tested. Then there's anxiety waiting for the test results. Referral of providers to licensing boards for disciplinary actions. You could see this. Next slide. This particular billboard was all over Nevada during that outbreak, and I don't think that this is something that you want outside your ASC or physician's office. These outbreaks lead to malpractice lawsuits that are often filed by the patients. And most importantly, it's certainly costly to patients, providers, and the health department because they have to have all these resources to investigate these outbreaks. Next slide. So let's talk a little bit about understanding the basics of transmission. Next slide. So really, when we're talking about safe injection practices or unsafe injection practices, we're really talking about indirect contact transmission. And basically what that means is that we're going to have the transfer of an infectious agent through a contaminated intermediate object or person. So the intermediate object or person could be the hands of healthcare professional, patient care devices such as glucometers, instruments that aren't adequately reprocessed, and of course medication and injection equipment. Next slide. The things that are often transmitted, we're most worried about bloodborne pathogens, and so unsafe injection practices can certainly expose healthcare workers, patients, or residents to viruses that can cause illnesses, Hepatitis B, Hepatitis C, HIV. And you notice there I have the risk of transmission from a needle stick there. And you know, some of the risk is fairly small, but I would still be concerned if I was part of that 0.3% risk. There are so many devices these days for safe needles, and that will put a shield or something over the needle, you know, after you're drawing blood or even after giving medication, that there is absolutely no reason that anyone should be taking a needle and trying to manually put that needle back into its cap. And if you don't think it happens, I saw it in a patient room 2 days ago. Next slide. So this is very simple. You have a source. This is an infectious person who either has chronic or acute viral disease, hepatitis or HIV. Could also be bacterial disease. Equipment is used on them. Now that equipment or medication is contaminated, and then with no cleaning or disinfecting, that same equipment is used on a person who has a compromised immune system or is in general susceptible, and they receive that present of that infectious agent. Next slide. I really liked this depiction of how the hepatitis C outbreak happened in the Nevada case. And basically what happened was they started out with a new vial, a clean needle, and a clean syringe. They drew up the medication, and they administered it to a patient who they didn't know had hepatitis C, but they did. And by giving that person that injection, some of that hepatitis C virus flowed back into the syringe. And you can see the little X's in the syringe on the next part of the picture there. And so they really thought they were doing the right thing because they changed needles, but they used the same syringe. They went back into that same vial to draw up more medication, and when they did that, they transmitted what was in the syringe to the vial. Then they got a new needle and a clean syringe. For the next time, they drew up out of the same vial, so they're using this for multiple patients, and they drew that hepatitis C virus right into that syringe and injected it into another patient. So it's not a complicated model. Next slide. So now we'll talk about some of the about prevention and the safe injection practices that we should be using. Next. So the model for basic patient safety really means that healthcare should not provide any avenue for the transmission of bloodborne viruses. All of these outbreaks that we talked about are entirely preventable events. They did not need to happen. Next slide. One of the first things that we need to do when we talk about safe injection practices is we have to use aseptic technique. And I'm sure that everybody says, oh, I know what that is, but knowing what it is and actually practicing it is two different things. And sometimes it actually becomes difficult sometimes. So it really needs to be a thoughtful process when you're doing an injection. And basically, aseptic technique is handling, preparation, and storage of medication and all the supplies used for injections or transfusion in a manner that's going to prevent microbial contamination. So like I said, it really needs to be a very thoughtful and purposeful practice that we follow. Next slide. So let's talk a little bit about medication preparation. So number one, we want to use standard precautions. The second thing is we need a clean area that's free from contamination or contact with blood, body fluids, or contaminated equipment. Now, this may actually be somewhat difficult if your facility is short on space and you're using one area for multiple tasks. But when preparing medications, we really need to be mindful of that. So you really need any item that could come in contact with blood or body fluids really needs to be kept separate. And the other thing that we need to think about too is when we're preparing medications, they need to be done in a clean, dry workspace that's free of clutter, because you make mistakes when there's clutter, obvious contamination sources like water and sinks, because we know that water and sinks can harbor certain pathogenic bacteria such as Pseudomonas. So we need to be mindful of that too. Next slide. So this is a picture of an area that is used to prepare medications. And we'll just ask, do you think that this is an area that should be used to prepare medications? And the answer to that, I'm sure you all got the answer right, but the answer to that is no, it really shouldn't be used, because if you look kind of on the right-hand side of the slide, there's a little yellow box. That's a sharps container, disposal container, and this is also an area where phlebotomy is done. So blood specimens and phlebotomy specimens are also placed on that countertop. And I would suppose that the occasional urine specimen or other specimen may also appear there. So this would not be an appropriate place to prepare medications. Next slide. So other things that we need to think about when we're preparing medications is that they should only be prepared by trained staff. Make sure that they know exactly where to prepare the medications and how to prepare them. They should also be stored in a manner to limit the risk of tampering. And when we think about tampering, we can think about two different things. Tampering in the sense of the vials or medications could get contaminated, but tampering also in the respect that we don't want medications stored in such a way where people could actually take them or withdraw some of them or whatever. So that would really be like drug diversion kind of situation. And that's not really something that we'll be able to cover in this presentation either. That's kind of another presentation. But what goes along with that too is you should really verify the competency of those preparing medications and monitor compliance with aseptic technique. So like I said, you know, training is one thing, and we know what aseptic technique should be, but are we really practicing those techniques? Next slide. So single-dose vials should be used whenever possible. And I think one of the big mottos is right-sized vials and pre-filled syringes should be what we really use. And if you're using pre-filled syringes, they really need to contain the following information: the time that they were prepared, the person's initial, the med name, the dose, and the expiration date. And if any of those things are missing, you probably should not use that medication. These are all very important things that need to be on that syringe. Now, another thing to be aware of too is that the size of the vial does not always indicate single or multi-dose. So it's very important that you look at your vials and you make sure you understand what type of dosing you're dealing with, single or multiple. Next slide. So multiple dose vials, if you have to use them, they should be designated to a single person whenever possible. And both the needle and syringe used to access the vial must be sterile. So once again, a clean needle, clean syringe every time you go into the vial. And like the little picture on the slide shows, you should never leave a needle inserted into a medication vial septum for multiple uses, even if it's going to be in the same for the same patient. You just shouldn't do that. Next slide. So before the procedure, what we want to do is we want to carefully read the label of the medication vial. You want to visually inspect the vial to ensure that there's no visible contamination. In other words, if it's supposed to be a clear medication, is it clear? If it's cloudy or yellow and it's supposed to be clear and colorless, that vial should be disposed of. You want to understand from the label if it's a single or a multiple dose. If it is a multiple dose vial, you want to make sure you're using it for the patient it's been assigned to. You want to double check the expiration dates, and that means you want to double check the manufacturer's expiration date as well as the open vial expiration date. And if either of those dates has passed, when in doubt, throw it out. Next slide. To maintain the sterility of the vials, like we said earlier, you need to perform proper hygiene before you start to handle the medication. You need to use a new sterile needle and syringe for each injection. This is important too. You need to disinfect or scrub all the vial tops, and that includes after you take off. You grab the vial from the medication cabinet or whatever, and it's foil top on it. When you take that top off, you need to still scrub the top of that vial. I think that's a place where it's often missed, and people don't do it, and they think, oh, it had the cap on it, so it's still uncontaminated. And the fact of the matter is, what if you accidentally, and you didn't notice, touch the top of that vial with your hand, or somehow it could get contaminated. So you should always wipe that top off with alcohol from the moment that that cap is taken off. Of course, we know IV hubs and ports need to be scrubbed with alcohol for at least 10 to 15 seconds. You need to use vigorous scrubbing and allow it to dry before access. And after you use a syringe or needle that's been connected to either enter a vial or has been connected to a person's IV, it's contaminated and it should not be used for another patient or to connect to another IV. Next slide. Medications need to be discarded upon expiration, and anytime there's any concern regarding the sterility, we need to discard it. Leftover medication should never be pooled for later administration, even if it's going to the same patient. Never do it. Also, never store or transport medication vials in your clothing or pockets. Your clothing is contaminated, and you probably have all sorts of other stuff in your pockets. I know that when I worked in the hospital, my pockets usually had all sorts of stuff in it, but not medication or syringes or needles. Next slide. If a medication, if a multiple dose vial is being used, it should not be kept or accessed in the immediate patient or resident treatment area. So it should not be stored in the patient's room. Once again, there's a couple of reasons for that. Number one, you don't want anybody stealing that medication. Number two, there are visitors, and visitors are curious. So it could very well be that they see the medication, they're going to pick it up, and they're going to look at it, and more than likely they're going to contaminate that vial. So all medication needs to be prepared in an area specifically that's kept clean for medication preparation. So by doing this, this prevents accidental contamination, and these multiple dose vials really need to be dedicated to only one patient. So a little bit about infusions, the next slide. One of the biggest things is we don't want to use bags or bottles of intravenous solution as a common source of supply for more than one patient. So, oh, I have this great big bag, I can get a lot of flushes out of this. Not for more than one patient. Use fluid infusion or administration sets for only one person and dispose appropriately after use. It's hard for me to imagine that someone would be disconnecting an infusion administration set from one patient and think it was a good idea to take it down and use it on another patient. But if it's in the guidelines for safe injection practices, it probably happened. If you do spike an IV bag before it's immediately going to be used, you really need to give that administration within 1 hour of the bag being spiked. And irrigation solutions should be discarded between patients. Next slide. So after the procedure, basically what we want to make sure is we want to make sure that we discard all used needles, syringes, and single-dose vials. As soon as the procedure is over and in the appropriate disposal system, so more than likely a sharps container, we want to store those multiple-dose vials appropriately, and once again, don't use those multiple-dose vials beyond the expiration date. Next slide. Just some other best practices that we want to use when a spinal canal or subdural injection is happening. The person doing that procedure really needs to wear a surgical mask. I was really surprised about this, but there was actually an outbreak where I believe it was an anesthesiologist was giving an epidural to some pregnant women, and they did not wear a mask, and he gave these women streptococcus salivarius meningitis. And that's usually part of the normal mouth flora, and in this case there were 5 cases of bacterial meningitis that occurred, and one of those women actually died. So it's very important to make sure that practice is being carried out. When you administer eye and ear drops or ointments, use the no-touch technique, and if the tip of the container touches the patient, get rid of it. And you want to obtain topicals in the smallest unit dose and remove with a sterile applicator each time, no double dipping. Next slide. So in the time that we have left here, let's talk a little bit about glucose monitoring and insulin pens and other point-of-care devices and safe practices that surround these. Next slide. So this list here are unsafe practices. We never want to use a finger stick device for more than one person. Blood glucose meters or other point-of-care devices, so think INR machines or hemoglobin devices, should never be used for more than one person without cleaning and disinfecting between each use per the manufacturer's instruction. Insulin pens or multi-dose insulin vials should never be used for more than one person. And this is an interesting one. An unsafe practice, of course, is failing to change glove and perform hand hygiene between finger stick procedures. So just because your glove doesn't mean you can move on to the next patient. Change your gloves, dispose of those gloves, and wash your hands. Next slide. So what should you do when you're preparing to do a point-of-care procedure? So the first thing you want to do is gather all your supplies and make sure you have everything to do the procedure. But then you don't just want to put those supplies down on the bedside table or on the bed. We really need to use a clean field. So it doesn't need to be sterile, but it needs to be clean. So put a paper towel down, or get a little drape and put that down, and put the supplies you're going to use on that field so that you can work from that. But think about this too. If you're going to be doing multiple procedures, you need to change that clean field between patients, because a clean field is only clean once. Once you've done one patient, now it's a dirty field, so you need to change it. And like I said, you need to have everything for the whole procedure accessible. Next slide. So obviously we want to perform hand hygiene before we put on our gloves, and you want to perform hand hygiene immediately after glove removal and between patients. You should wear gloves when performing finger sticks or insulin injections. You should change your gloves between patient and resident contacts, after touching finger stick wounds or potentially contaminated objects or equipment, and before touching clean surfaces. So you do the finger stick, you get it taken care of. Now before you go to enter it in the computer or whatever, take those gloves off and wash your hands, and then do your clean surface work. And of course you want to make sure that you discard those gloves in the appropriate container. Next slide. So safe practices. Finger stick devices are not used on more than one patient, and this includes both the lancet and the lancet holding device. You should be using single-use devices that permanently retract upon puncture. These devices are readily available, and they're cost-effective. And so if you're not using a device that retracts that lancet after it's used, you really should look into purchasing something like that. And insulin pens and other medication cartridges and syringes are once again only for single use and should never be used for more than one patient. Are you getting that that's kind of a reoccurring theme here? One set of equipment, one patient, right? Okay, next slide. So other safe practices. Oh, can you go back to that other slide? Did anybody notice something in this picture here? I hope you're all saying it out loud, but the woman there, she's doing that finger stick. She doesn't have gloves on. So that's certainly, she's actually not only exposing the little baby to risk, but she's exposing herself to potential transmission. So yes, I found that slide. So people still are doing things like this. Next slide. We'll go on. So when, once again, you should be using dedicated glucose meters to a single patient. And if you do have to share the device, you need to make sure that it's cleaned and disinfected per the manufacturer's instructions after every use, because blood can be transferred back to the glucometer when handled to obtain the reading. And if your manufacturer cannot provide you with instructions for cleaning and disinfecting the device, then you need to get a different manufacturer, because all the manufacturers should be providing that information. Now, where this particular best practice falls down is when there are no clear-cut guidelines for who is responsible for doing the cleaning. And so I think that needs to be something that's very predominant in your procedure, and the staff is well educated on whose responsibility that is to clean the meters. Next slide. So the next few slides here are really the CMS IC surveyor worksheet, and you can get this worksheet if you just put CMS IC surveyor worksheet into Google. It will certainly come up, or in the CMS website. And basically, you can just skip through the next couple of slides here. This worksheet, this is the section on safe injection practices. Keep going. And it outlines everything that you need to have at a minimum in your infection prevention and control policy in regards to safe injection practices and actually the use of point-of-care devices. So certainly that's something that you need to have in your facility and use that when planning your policies and procedures. So in summary, I think one of the biggest things is, you need to have a dedicated person who's responsible for infection prevention in your particular healthcare setting. You do need to include safe injection practices in your risk assessment and your infection prevention program. This is where this belongs. You need to assess that risk. You need to assure that existing policies reflect the latest recommendations and guidelines, and you need to monitor what practices are occurring in your facility. Are they consistent with your policies? What are the consequences for not following the policy? Next slide. I think that education and training is imperative to learn each person's roles and responsibilities in preventing infections, and your staff needs to be trained based on your policy, not what other staff people have been doing. So I can guarantee if you go through your facility and you ask each of your workers, are they following the policy for safe injection practices? They will say absolutely. But then upon observation, you'll find that apparently their policy is not the center's policy. So it's important to make sure that what's on the books is what's being practiced. And one of the ways that you can keep a tab on that, and I don't have that bullet on this slide, it should be there though, is in addition to periodic training on these things, there should be competency testing. So not only just having somebody verbally tell you what needs to be done, but having those who perform these procedures actually show you what they're doing. That is becoming certainly a big thing these days. And then in conclusion, there's tons of resources out there. Next slide. These resources, this is the, oops, they're not there. There's resources from the CDC that are available. If you just type in safe injection practices on the CDC website, oh, there they are. It will come up. Next slide. If you go to the one needle, one syringe, only one time campaign, and there's the website there, that gives you all sorts of resources. Next slide. APEC, if you go to the APEC website and you type in safe injection practices, whether you're a member or not, you will get information on what you need to do. And there is the ASC Quality Collaboration, next slide, that also has information on safe injection practices. And the next slide, go out to YouTube and take a look. I was really, well, I shouldn't be surprised, but there were tons of YouTube videos. This particular one was really cute, and it was on target and on point. It was 4 minutes long. So something like this might be very helpful in starting a training session with you. And so with that, that concludes this presentation, and I am available for questions and answers.
Thank you, Barb, for a very informative and enjoyable presentation. We are now going to begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenter will attempt to answer as many questions as she can during the time we have for Q&A. So Barb, one attendee is wondering, is it advisable to use gloves in the administration of intravenous medications?
Okay, so that is a very interesting question. I was just at the APEC meeting this past week, and there was a whole session that they had on, it was called To Glove or Not to Glove. And they talked about giving injections, and the presenters indicated that it was not a guideline or a recommendation that gloves need to be worn when you're giving an injection. So we use, and this could be another whole topic too. So we often use gloves very inappropriately. Gloves should be used when there is the potential for coming into contact with blood or body fluids. And the potential for coming into contact with blood or body fluids when giving an injection is certainly small, because when you're giving the injection, because I said, well, you know, oh, well, what if the person bleeds a little bit? And they said usually you have a cotton swab or whatever, and it's not so tremendous, you know, blood that it could safely be contained. That being said, you could also think about it, well, if there's any potential, you'd want to use gloves. So, so I just gave you a two-sided answer there, but I think that people have adopted using gloves as a best practice for injections, but it's not actually in the guidelines and the recommendations. So I don't know if that answered your question or not, but it's something that's being raised out there.
Thank you, Barbara. Another attendee is wondering, can you reuse a multi-dose vial in the emergency room if it is not placed in a patient room?
So so you're going to use it on the same patient, correct? Okay, so you can use a multi-dose vial with the same patient, but you need to make sure that you would have labeling on that vial that would indicate it is for that patient. Okay, now I could see potential for, you know, possible misuse of that, because if you're going to put it back in the medication room, would someone else possibly pick it up, you know, and use it? I think you'd have to look at your particular situation and in your risk assessment decide, you know, how much of a risk that might be. But, you know, the guidelines and recommendations say you can use multi-dose vials, but it needs to be for the same patient and not multiple patients. So you would probably need to label it with the patient's name and also the open vial expiration date.
Thank you, Barbara. And another attendee is wondering, what kind of documentation from vendors should they keep on hand to prove that the irrigation solutions may be used for multiple patients? And this question is in reference to the anthrax tubing that has been FDA approved for this.
Okay, I'm not really familiar with that particular tubing, but I would say that the vendor, that should really be part of the intended use of the irrigation solution. You know, that, you know, it's used for this and can be used on multiple patients. And I would also think that, so this would be like in your instructions for use, okay? And they always have an intended use for the product or whatever. And I think there would also need to be instructions for how to use that safely in multiple patients. You know, that would be my opinion on that. As I said, I'm not familiar with that particular type of tubing. But if they don't address that in their instructions for use, it might be kind of difficult for you to defend that on a survey.
Thank you, Barbara. And when you're using a a multi-dose vial of insulin. Why should providers not use this for more than one patient, given the fact that the vial is prepared and aseptic technique is used when drawing up medication in a separate area away from the patient?
Well, because there's always potential for contamination. So it would just take one person to enter that vial with a syringe that is not clean or new and sterile, and that that vial could become contaminated. And so I think just in the I think that recommendation has been put into the guidelines because look at all the outbreaks that have happened, and I think it's very difficult in some cases to really be absolutely positively sure that somebody's not going to use a syringe or somebody's not going to reuse a needle. Even though well, nobody's going to do that in our institution, and everybody knows that that you're not supposed to do that. I mean, how many times do we say that in this webinar? But I think that the risk is exceptionally high based on past history, that in order to mitigate that risk, that was what the recommendation is. And they may have additional evidence, scientific evidence that backs that. We could go back to the guidelines and see. Usually they have references that indicate why they came to that conclusion and how strong that evidence is.
Thank you. And I want to thank Barbara again for her excellent presentation and for all of you who participated today. We are looking forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.